Welcome to the body imaging cases. This is a 36-year-old male with seizures. During history taking and on asking those who witnessed the seizures, a nurse, which happened to be among them, expressed her impression that the patient may have had hypoglycemia. CT of the head has been performed and it revealed multiple intracerebral calcific lesions suggestive of neurocysticercosis. MRI has been consistent with the diagnosis of neurocysticercosis. 2 lesions were identified. These are the details of one of the lesions, which is located at the postcentral gyrus. This is the unenhanced T1 weighted MRI, and after injection of contrast agent, there has been mild enhancement, and the calcification expressed itself as blooming on the susceptibility weighted images. This is 3-dimensional representation of the gadolinium enhanced T1 weighted MRI of the head. The lesion is encoded in green at the postcentral gyrus. The central sulcus is marked by the dotted yellow line. The patient had an attack of seizures during his hospital stay, and his medical workup at the time of this attack revealed significant hypoglycemia. So the initial crude impression of the nurse who witnessed his seizure outside the hospital proved to be true. This patient has been hypoglycemic. Insulin level proved to be high, and therefore the diagnosis of insulinoma was suggested, and he started the imaging search for this insulinoma. A small lesion is seen at the pancreatic body on the fat-saturated T1 weighted MRI, and it enhances strongly on the early arterial phase of the dynamic gadolinium enhanced study. Subsequently, it cannot be identified as the contrast agent equilibrates between the lesion and the surrounding pancreatic parenchyma. This is a subtracted image of the arterially enhanced MRI minus the unenhanced corresponding image, showing enhancement of the lesion, which is consistent with insulinoma. Although the lesion cannot be seen on the delayed gadolinium enhanced MRI, comparison of this image with the unenhanced image shows very well that you are having a lesion here which is enhancing. On the diffusion weighted image, the lesion is seen, but it cannot be distinguished from the suprapancreatic lymph nodes adjacent to it, as they are having the same signal intensity on all the steps of the diffusion weighted images and also the ADC. The lesion cannot be seen on the T2 weighted images, and we know that because we know the location of the lesion just to the right of this splenic artery. The signal intensity difference between the lesion and the pancreatic parenchyma is not enough to allow detection of the lesion on T2 weighted images. The same applies for this sagittal image, in which the lesion is located posteriorly and superiorly at the pancreatic body. There is mild hyperintensity of the lesion, but this hyperintensity is not enough in itself to detect the lesion and to take the drastic action of surgery based on that. Also on the coronal images, there is mild hyperintensity of the lesion, not enough to make the diagnosis. So the diagnosis is made on the MRI actually on two types of images: the unenhanced T1 weighted images and the early arterial phase. This is a 3D representation of the fat saturated T1 weighted MRI of the pancreas, on which the pancreas becomes very bright. Here we see the lesion on the posterior superior aspect of the pancreatic body. Now we are fusing the contrast enhancement extracted from the subtracted image on the unenhanced fat saturated T1 weighted image. And this is how the lesion looks like looked at from posteriorly. To prove the relation of this lesion to the hypoglycemia of the patient, that's to say, to know the functionality of the lesion, a TNF-DOPA PET-CT has been performed in the hope that uptake of the tracer by the lesion would prove its neuroendocrine nature without the need for a biopsy, but unfortunately there has been no uptake. Gallium-68 DOTA-NOC has been tried. There is very little uptake at the site of the lesion, but this little uptake is not enough to justify the presence of a neuroendocrine tube. It is more or less similar to the background uptake at the rest of the pancreas. Based on that, endoscopic ultrasound has been done and it clearly showed the lesion. Elastography revealed that this lesion is solid and more rigid than the rest of the pancreatic parenchyma. And ultrasound guided biopsy has been done during the same examination and confirmed the presence of an insulinoma. This is the needle pointed to by the blue arrow and the lesion by the yellow arrow. CT angiography has been performed to know the arterial anatomy, as on the MRI the splenic artery was suspected to be arising from the superior mesenteric artery. On this unenhanced CT, the lesion has the same attenuation value as that of the pancreas. On the arterial phase of the CT angiography, the lesion shows a central dot of enhancement, and on the subsequent phase, the lesion returns back to the same attenuation value of the surrounding pancreas, or slightly higher. The arrow points to the splenic artery, which in this case proved to be coming from the superior mesenteric artery without any other arterial abnormalities. A good trick here to know that the central dot of enhancement within the lesion is not a vessel is to use thin maximum intensity projection. Using that, you can see that the arteries are changing to tubular structures, while this dot at the center of the lesion remains a dot. This is the vascular ultrastructure of the lesion, showing a central dot of intense enhancement from which other branching vascular structures are spreading into the lesion. And this is taken from the three-dimensional reconstruction of the CT angiography, which we will see now. Here is the lesion pointed to by the yellow arrow. Here we have the enhancing lesion, and we see its relation to the portal vein and the hepatic artery. This demonstrates the distance between the margins of the lesion and the portal vein and also the splenic vein. And here we see the lesion pointed to by the yellow arrow, quite close to the splenic artery pointed to by the red arrow. The splenic artery is arising from the superior mesenteric artery. And this is, as we have seen, represents the ultrastructure, the vascular ultrastructure of the lesion. Diagnosis was insulinoma. The patient has been operated upon by pancreatectomy of the pancreatic neck, body, and the tail, as well as the spleen. The surgical options were between this pancreatectomy and removal of the lesion only. Due to the malignant potential of some insulinomas and due to the proximity of the lesion to the pancreatic duct, the pancreatectomy was preferred. The learning points are insulinoma-related hypoglycemia may present by seizures. We need to be aware and beware of the satisfaction of surge error. We know this error in radiology when you see one abnormality and you get satisfied and do not look elsewhere, but it exists also in the clinical arena. In this case, there are seizures and there are 2 lesions in the brain which can potentially cause epilepsy. Had the workup been stopped at this point, probably the patient would have had unnecessary operation on his neurocysticercosis. However, the discovery of the hypoglycemia has suggested 2 scenarios, not only one. It has not been finally decided which of the 2 scenarios is at work. However, now that the insulinoma has been removed, the picture will be clear. If the seizures persist, the neurocysticercosis needs to be taken into consideration, and if the seizures stop, and this is most probably what will happen, hopefully also for the patient, then we will know that it is the hypoglycemia and not the neurocysticercosis which was behind the seizures. Insulinoma may be difficult to detect on imaging due to 2 factors. Its small size and the insufficient contrast to noise ratio with the pancreatic parenchyma. We have seen in the present case some bad guys and some good guys as far as detection of the insulinoma was concerned. These bad guys could not detect the insulinoma. True, in some of them there are subtle differences between the lesion and the pancreas, but these subtle differences are not enough to take the drastic action of surgery based on them. The lesion is very little hyperintense in relation to the pancreas on the 2 weighted images. It is exactly the same on the delayed gadolinium enhanced images and also on the delayed CT. It is exactly the same like the pancreas on unenhanced CT. And the 2 PET CT studies done with the 2 specific tracers for neuroendocrine tumors failed, in fact, to give a convincing evidence that there is a lesion, the DOTA-NOC and the DOPA. This doesn't mean, however, that we will term them bad guys forever. In certain situations, they are the good guys that will detect the insulinoma. The diffusion weighted image story is different. It is bad here because of its poor spatial resolution. It has depicted the lesion, in fact, but because the lesion is sitting on top of the pancreas and is neighbored by multiple suprapancreatic lymph nodes, and they appear exactly the same on this diffusion-weighted MRI. Therefore, diffusion-weighted MRI could not give the evidence here alone that there is an insulinoma that needs to be resected. These are the good guys. The fat-saturated T1 weighted MRI shows the lesions in the pancreas because the normal pancreas on this image is extremely bright. The arterial enhancement, both on CT and on MRI, gave strong evidence of the presence of the insulinoma, and probably the best of all in this particular case was the endoultrasonography. So we learned that one of the very important images to look at on pancreatic imaging are the fat-saturated T1 weighted images, preferably also with three-dimensional reconstructions. Visual comparison of unenhanced and contrast-enhanced images is important. Subtracted images are good, of course, but we have to take care of the misregistration when we are subtracting, which may create lesions or omit lesions, particularly when the lesions are very small, as in the case of the insulinoma. So in these particular situations, we may need to rely more on the visual comparison of the unenhanced and the contrast-enhanced images. Endoscopic ultrasonography is useful in diagnosis of insulinoma. In this case, not only to detect its presence, but it gave us knowledge about its consistency and firmness. On elastography, it is more rigid than the rest of the pancreas. Not only that, but on endoscopic ultrasonography, histopathology could be verified by the ultrasound-guided biopsy. Three-dimensional reconstructions provide a convincing evidence for the treating physician and a roadmap for the surgeon.